in the first place, right, how do we stop the reflux from
Wow.
happening?
Very, very important question.
Yes.
Very good question. So a lot of men and some women, they get their anti-reflux medication and been taking the antacids for many, many years, and so they haven't come to see a doctor. So
Yeah, it's
by the
very
time they
common.
come to see the doctor, it's quite advanced already.
I also see these symptoms in children,
Yes,
teenagers.
yes.
So it's very dangerous actually
So
to have this.
that's it.
Hai semuanya, saya Ira dari Ohana Medical Group. Hari ini saya bersama Dr. Edward Cheong dari Pan Asia Surgery di Mount Elizabeth Novena. Hello, Dr. Cheong.
Hello.
Yeah.
Thank you for having me.
Yeah, thank you. Dr. Cheong, today I want to ask you more about esophagus.
Yes.
Yeah, because I noticed that the symptoms for esophagus illnesses is somewhat very common that a lot of people is having experience it. It's like heartburn, is it?
Yes,
Yes.
indeed, that's true. 1 in 5
Yes.
of us suffer from significant acid reflux
Mm.
or heartburn.
Mm.
And this is quite a significant problem because if left untreated long term, it can lead to the development of Barrett's esophagus and esophageal cancer.
I see. So what is actually the function of esophagus and how does it works?
So the esophagus is a tube, if you can see, between the mouth and the stomach. And its role is to transfer food into the stomach from the mouth. And its role is also to stop anything refluxing back from the back of the top of the stomach, back up the mouth, and into the back of the mouth or into the airway. So that's the role of the esophagus.
So there's a flap that
There is a valve
closing.
there, that's right. That's called the lower esophageal sphincter,
Okay.
and that's is loosened or weaker in those patients with acid reflux. But if this fails, then there's a second valve at the top, known as the upper esophageal sphincter
I see.
muscles. So typically, they would have a dysfunctional lower esophageal sphincter, and when they eat, or if they eat too much, they get a lot of acid and bile going up the esophagus and creating the sensation of heartburn, and that's what it is.
Okay. So that means if we have acid reflux, we have gastric problem, this can create irritation of the esophagus.
That's right.
Yes.
So the acid reflux and the bile, which we often forget, creates a lot of inflammation. And the inflammation of the lining over many, many months and over many, many years leads to the changes in the lining of the esophagus, which is called Barrett's esophagus. And that is pre-malignant.
Okay.
And often this reflux will continue insidiously, because when the Barrett's esophagus develops, the patient no longer has this sensation of heartburn because the esophagus has adapted to this inflammation. So they have this false sense of security that nothing is going on, but actually they are still having a lot of problems. So that is the big problem.
So in the first place, right, how do we stop the reflux from
Wow.
happening?
Very, very important question.
Yes.
Very good question. Now, stopping acid reflux, you need 3 very important things. 1, they need to change their diet.
Okay.
2, they need to change their lifestyle and stress. And 3, they need to learn how to take the medication to prevent acid reflux correctly. So let's start with the diet. So diet, generally simple, avoiding things like alcohol or smoking, anything that is acidic or spicy, cheese or fatty food, which also delays your gastric emptying, so it creates more reflux. Overeating, eating too quickly, like they gorge the food down, or eating too much late at night before bed. That's a bad idea. other big issue is a lot of people have reflux, but they also have a glass of water by the bedside. So when they get up at night to drink, or they drink just before going to bed, the water goes into the stomach, mixed around with the acid in the stomach, but when they lie down flat, the water flows all the way back up again the esophagus, because the lower esophageal valve do not work, and so it burns throughout the whole night while they are asleep. So that's a huge issue as well. The other thing I spoke and I haven't mentioned about is, if you have reflux, you should try to sleep on an incline. Certain foods I mentioned briefly that causes acid reflux, such as acidic food. So we already talked about spicy food like the chilies and the mala. Acidic fruits or citric, like the lemons and oranges. Those are the acidic ones. Tomatoes, they contain malic acid, so they also contribute to the acid reflux as well. So we tend to try to cut down on it. And if you are overweight, then try to gradually lose weight to get back to the target weight. So smaller and smaller, and it's quite important.
How does overweight impact this? Is it like it squeezes the
So the overweight story is not that straightforward, as in just an increase in your abdominal pressure, and then you got a hiatal hernia in the diaphragm, and then it pushes everything up. But long before that happens, the patients tend to overeat. So when they gorge themselves, they stretch the valve, the lower esophageal sphincter valve, every time they eat, and they eat too fast, and they stretch it. And if you do that millions of times a week, then the valve is going to remain quite loose after a while. So that's the long and short of it. But of course, when you develop the heavy weight, your abdominal pressure is higher than your chest, so it tends to push things back up. But thin people can get acid reflux as well. Thin people can get hiatal hernia. Thin people can have a weak lower esophageal sphincter valve as well, because they tend to eat too fast, too much, too quickly. They gorge themselves with food. So it's a long-term process of it. It's not just a genetic thing, but there is a small genetic component as well.
So actually, how long does it take for the stomach to digest the food? How long after you wait until another?
The good idea is that when you eat, especially in the evening, let's say you got a patient with acid reflux, when they eat in the evening, try to eat a little bit earlier, say 2-3 hours before going to bed. And after you had dinner, those with nocturnal acid reflux, I tend to tell them 2 to 3 hours before going to bed, let's say 2 hours before, avoid anything to eat or drink. And if their mouth is dry, then go to the tap with tap water, gargle, rinse, but spit it out, don't swallow. And that glass of water by the bedside, get rid of it. And the same thing happens in the middle of the night. If they have a dry mouth or dry throat in the middle of the night,
Gargle.
just rinse your mouth with tap water, gargle, spit it out, don't swallow.
So 2 to 3 hours before dinner, that's the last time you
Yes,
ever
right.
eat, and then no drinking before bedtime.
And if you're having a big meal, try to have the big meal at lunchtime or earlier, and try to have your evening meal as the smallest meal of the day. And that's the way to do it.
You mentioned also about stress. That
Stress,
can cause-
exactly. So lifestyle and stress. So we live in a very fast world, and it is important to realize that smoking, alcohol, they relax the lower esophageal sphincter. Stress creates a lot of acid secretion from the stomach, and because of the stress we create in our mind, it also affects our body. So if that's constantly, and I haven't mentioned having a good sleep, 7 hours or 8 hours of good sleep. So if you don't have a good sleep continuously for many weeks, then that's going to affect your whole health and your body as well. So everything everything plays a part. Right? It is very important. And then finally comes the third thing, is medication. So I mentioned that you need to control your diet, you need to control your lifestyle and stress, and you need to control your medication. If you don't do 3 correctly, it will never work. You can't just do 1 and hope the rest works in place. When you take your medication, especially for the antacids, try to take it about 30 minutes before you eat. But those patients with acid reflux at night, so the nocturnal acid reflux, I get them to take their medication roughly 2 hours before going to bed with a tiny glass of water. So that it stops them getting any acid reflux throughout the night. The half-life of these drugs, that means the drugs work predominantly for about 12 hours predominantly. So if you take it at, let's say, 9 or 10 o'clock at night and you go to bed at midnight, then you're almost certainly covered throughout the whole night when you're asleep, so you don't get the burning sensation at night. But it's acid reflux is not just about diet, it's about the lifestyle, it's about the stress, it's about how you take your medication, it's your sleep, everything plays a part.
Okay. So maybe now we know that we have to maintain a good lifestyle and eating habits and everything to prevent the valve to be irritated and inflamed. Is it?
That's right. For preventing chronic acid reflux or esophagitis.
Because in long term they can create cancer in the esophagus.
That's right. So long-term acid reflux leads to Barrett's, which subsequently can lead to esophageal cancer, and that's the biggest rise cancer in the world at the moment. We've seen over 500% rise since the 1970s. The other big thing to remember is that in Asia, most patients with acid reflux do not have a big hiatal hernia. So what we can do to help them, apart from the medication, we can do a procedure endoscopically as a day case, which takes less than 15 minutes.
Gastroscopy.
With a gastroscopy, it's called anti-reflux mucosal ablation. This is to tighten up the valve a little bit so they get less reflux. So we work with them to change again their diet, their lifestyle, and stress, and to take the medications. But we also try to tighten the valve with this procedure called ARMA, and this anti-reflux mucosal ablation. So this is done as endoscopy through the mouth. No cuts, no surgery. It is done in 15 minutes. So it's quite fast.
Permanent solution or?
It's a solution to help the patient to cut down on the medications. But again, they have to be very mindful that their diet, their lifestyle, right? They have to do it. They still have to change it. It won't work long term. In fact, none of the anti-reflux surgery will work long term if the patient's diet, lifestyle, and stress is not fixed. So it will just fail, even in the best centers around the world.
So it happened that this can cause cancer in the esophagus. What is the treatment available?
Now, if you have esophageal cancer, then it's a totally different game. The whole idea of the reflux to prevent cancer and to prevent a cancer surgery. Now, if you have reflux long term, you should get the endoscopy to check. And if the biopsy comes back as very early cancer, we can still treat it endoscopically through the mouth. And it takes less than 30 minutes. We can burn it away or we can cut it out only for the very early cancers, like Barrett's with high-grade or low-grade dysplasia, or even Barrett's with intramucosal cancer. But if they are bigger, more advanced than that, as we see in over 70% of cases they're more advanced, then they may have to go for chemotherapy and then surgery. Some of them will have immunotherapy as well as the chemotherapy, and that's another ballgame. And in the last 30 years, we've noticed a significant change. Our surgery have moved from open surgery, big cut in the abdomen, a big cut in the chest, to tiny keyholes. So about 10 millimeter size holes, tiny keyholes. That allows you to have less pain after the operation and a much faster recovery. So instead of spending 6 months to recover, from the pains and the aches. The recovery is within weeks.
So when people have esophageal cancer, the chemotherapy is basically to reduce the size of it.
That's right. So chemotherapy, immunotherapy, they are systemic treatment to try to reduce the size of the cancer.
But
But
surgery
also
is the best.
also to prevent recurrence later.
Mm.
So the chemotherapy or the systemic treatment is important along with the surgery. They play a part together. You cannot just try to do one for those with more advanced cancer. You can't do one and the other because you need to clear them up systematically.
Okay, when you say advanced, what is the definition of advanced?
Okay, our definition of advanced is that this cancer has passed more than the mucosal lining of the esophagus. It is quite thin. So the probability is that it has spread into the system, to the lymph nodes and target. There's also a stage where we call advanced cancer, where this cancer has spread elsewhere to the liver, the lung, the bone, the brain, and that's a different treatment again. That will require often chemotherapy, perhaps with immunotherapy, or targeted therapy, and even radiotherapy, depending on the cancer type. There are largely two types of esophageal cancer. One is, I mentioned, Barrett's esophageal adenocarcinoma. That's due to reflux. The other one is squamous cell cancer. Squamous cell cancer is largely due to chronic inflammation, alcohol, smoking, and those are the lifestyle factors that affect the lining of the esophagus. So that is more responsive to chemoradiation. So they get chemotherapy and radiotherapy before we go for surgery. Although we now know that for those who can tolerate and can do very well, that a strong chemotherapy before and then surgery and then chemotherapy again after will have a very good overall survival long term. So 60% of them do well for 5 years, which is very, very important, because 30 years ago, less than 20% survival. And now we're talking about 50 to 60 with the help of chemotherapy and surgery combination.
So you mentioned if it's detected early, it's easy to do. You
That's
can
it.
do endoscopies for
Correct.
the surgery, right? But then, what is the symptoms? To know. Oh, okay, I have to do something about it.
Okay. The symptoms are vague. The three things that you have to remember is prevention is better than cure. Prevention is cheaper than cure in terms of your treatment. Prevention is easier than cure, which means if I can find a cancer early, I can remove it endoscopically with a gastroscope. Some patients have no symptoms. Some patients ignore the symptoms. Some patients have very mild symptoms. The symptoms are largely long-term acid reflux, difficulty swallowing, food getting stuck from time to time, even mildly, having a discomfort behind the chest bones.
Okay.
Those are the
Early symptoms.
early to late signs. So some people, very early cancers have no symptoms apart from acid reflux or heartburn.
Oh, okay. So that means it's important for us to do gastroscopy.
Very important,
Uh,
especially from the age of 45, 50, especially if you have symptoms of heartburn, especially if you've got a family history, and even more higher risk for patients who have drunk a lot in the past, they smoke a lot. So those are the higher risk factors.
So when we do gastroscopy, how long apart can we do it? Is it like
So it depends on the first. It depends on the first endoscopy and what you find.
Yeah.
If the first endoscopy you find nothing, you can wait from 5 to 10 years
I see.
and then repeat it again. But if the first endoscopy you found Barrett's or you found nodules, then you're gonna be depending on the histology. If the Barrett's does not come back with dysplasia, then you're not worried.
Okay.
If there is dysplasia, then you gotta treat it. Usually it's combination of anti-reflux medication and endoscopic treatment for them. But this doesn't work long term unless you are ready to stop your alcohol, stop the smoking, change your diet so that it stops you getting chronic constant acid reflux. The problem we have with the pharmacy and over-the-counter drugs is it's so easy to get antacids. So a lot of men and some women, they get their anti-reflux medication and they've been taking the antacids for many, many years. And so they haven't come to see a doctor. So
Yeah,
by the
it's
time
very
they come to see the doctor, it's quite advanced already because they forgot that there is a treatment.
I see. Yeah.
So they go to the pharmacy and the drug company that gives over-the-counter drugs. That's a very important place to advise the patients as well.
But I thought, Edward, I also see these symptoms in children, teenagers.
Yes.
So it's very dangerous actually
So
to have this.
That's it. So they've had it since they were young. But that comes with the genetic component from the family, the diet as well, because the whole family will eat the same kind of food, and obviously related to their background as well. And then if you watch the parents who give Gaviscon to the kids and or a tablet that they can get over the counter because it's so easily available and they don't have to go and see a doctor, and it's cheap that way, but they still haven't gone down the road getting a diagnosis.
So esophageal cancer is a long-term symptoms, then you get this, right?
Yes.
Okay.
So we talk about chronic inflammation, but usually the patients where they have symptoms in their 30s and 40s and 50s, and they've ignored it for a long time, and they've gone and treated simply with just over-the-counter antacids.
Because this kind of symptoms, we think of it as a normal.
That's it. They think of it as normal, so they and it's a first world, second world. We're always working, we're always stressed, we're always running from place to place, and you can just take a tablet in the mouth or a Gaviscon and you just carry on, and that's what we do. We forget that there is a problem inside, and the diet we have irregular meals, we skip meals. That's the worst part as well. So don't skip your breakfasts. Breakfast is probably the most important meal. So they skip meal. They only eat once a day, and they eat at dinner time, whereas they have a coffee and nothing else. So the acid in the stomach is still being secreted. It's still secreted, but it's digesting.
No matter whether you eat or not, it will still
be secreted.
Secreted.
Yes, exactly. And so especially when you're stressed. And then it's secreted, and then it cuts into your lining of the stomach, and then chronically you get a problem. And this is the type of patients we see quite a lot.
So I wonder if like after surgery, after chemotherapy, what was the outcome of the patient? Like, will they still be able to eat normally?
Yes, okay.
Will they,
So because most of the time we use the stomach as a tube, we remove roughly about 50 to 60% of the stomach, and then we create a narrow tube to replace the esophagus that's been removed. So because the stomach is much smaller, about this narrow, then it's important for them to learn how to eat smaller amount but more frequently. So this is something they have to do for the rest of their lives because of the operation is permanent. But it will take them about 9 months to 1 year to relearn how to eat and chew, eat slowly and eat slowly, and they eat it every 3 to 2 hours.
more frequently.
Initially, after the operation, I usually give them a very soft diet. So anything that you can, as soft as mashed potato with gravy. So anything that you can put your fork through it, that is soft. That's the consistency for the first 2 weeks, and then they start normal. But they make mistakes the first 9 months to a year, and they realize that if they overeat, they vomit, or they get a lot of chest pain, and they back off. So, and then they'll tell you they had vomiting, and I'll tell them, if you're vomiting after you eat, you have overeaten. So you learn to eat small, and
More frequent.
and more frequent every 2 to 3 hours. And they learn to have snacks in between meals. And a simple way of eating snacks is just 2 cheese crackers or your Jacob's crackers and 1 soft cheese like Laughing Cow cheese in between. That's a very good high protein, high carbohydrate, high fat snack, and that will last them another couple hours. So it's very, very important.
So if I see the picture here, you are actually will cut the cancer here, or
That's
then
right.
join back, is it?
That's right.
Oh.
It's
So that's why it's
we try to-
shorter.
we use the stomach,
Uh-huh.
and we create a narrow tube with the stomach here. So that, and then when this esophagus is removed, this narrow tube we put it through the diaphragm and rejoin it up there, either in the chest or in the neck, but the top of the chest.
So the tube will go inside the esophagus.
The tube will go. This tube will go to the chest, and then rejoin into with its esophagus high up.
I see.
So it's very it's quite a complicated operation. It's probably the most complicated operation we do. Yeah, and it's life saving if done properly. And like
They
I say,
can continue their normal
they
daily life.
do better than
Yes.
they think. It's incredible how much fear there is in society. Because in the past, this operation was badly done. A lot of patients did not survive, or if they survived, they had a bad quality of life. But if you teach them carefully and you teach them to get over it, they do very, very, very well. Yeah.
Okay. Thank you so much, Dr. Edward.
No problem. Thank you very much for having me. Thank you.
Jadi teman-teman, kita mesti jaga lifestyle kita, makan yang teratur, terus harus tidur, kontrol juga stres supaya kita tidak mempunyai masalah dalam esophagus kita. Terima kasih atas sudah menonton acara pada hari ini. Sampai bertemu lagi.